how to get what you want when you're asking for something, and how to make your no stick when you're trying to say no. How to stand up. The first is interpersonal effectiveness skills, which is in effect how to be effective in conflict situations. In particular, how to get what you want when you're asking for something, and how to make your no stick when you're trying to say no. How to stand up for yourself, asking and saying no.
I'd like for you to think of some situations in your own lives that we can practice with.
This skills training group includes both family members and patients. They will be practicing an interpersonal effectiveness skill called Dear Man. This exercise is adapted from a similar one developed by Bowers and Bowers of Stanford University. Each letter serves as a reminder of the target behavior that patients are taught. These are: describe the current situation, express feelings and opinions, assert by asking or saying no, reinforce the person ahead of time, be mindful of objectives without distraction, appear effective and competent, and negotiate without the talk. These are: describe the current situation, express feelings and opinions, assert by asking or saying no, reinforce the person ahead of time, be mindful of objectives without distraction, appear effective and competent, and negotiate alternate solutions.
What I want is for Kim to ask and you to try to respond, but we're also going to be looking not necessarily to solve the problem, but also to look at afterwards how you felt about the way she phrased it, and Kim, how you felt with how he responded.
It seems to me that you've been awfully interested in the things that I'm doing in my day program, and the people that I'm hanging out with, and the people that I'm dating, if I'm dating, and every little thing that I do. And you keep asking me questions, and I understand that maybe you're interested in my well-being, and I really do appreciate it. But I really feel overwhelmed.
Improving interpersonal skills helps decrease feelings such as interpersonal chaos and fears of abandonment. The second set of change skills are called emotion regulation skills. Regulating emotions allows patients to decrease feelings of anger, fear, shame, and sadness. Again, the aim of group skills training is to meet specific behavioral deficits associated with borderline personality disorder and to replace them with positive beliefs and behaviors that will help patients learn to solve their own problems.
Even though I knew that this was just role play, I started really feeling like, oh no, I really can't do this on my own. I really do need to depend on mommy and daddy or my parents.
No, disaster. So what got you back because you didn't react that way?
Well, what it was focusing in on what I was doing and what I was trying to get across.
Being mindful.
Being mindful.
These and several other psychoeducational skills are described in more detail in this training manual written by Dr. Linehan. The manual also contains worksheets suitable for reproduction and distribution. Treating patients with borderline personality disorder can be a difficult and often frustrating experience for therapists.
And Wednesday, she missed my session, didn't call, which is unusual for her, didn't return my call until I reached her next morning, lied about why she didn't make it.
She's now missing in action again and has been since, I guess, Friday night, which is her pattern. It's her consistent pattern of working Monday through Friday. She's like got apparent competence down. I mean, she's just amazing.
She has spent more years fooling doctors than I have been a doctor. And she's done it as a life and death issue every day. I'm not that good.
To help therapists cope with these patients, DBT takes a team approach. Just as there is consultation of the patient by therapists, there is also consultation to therapists by a team of colleagues.
The consultation to the team is based on the notion that the relationship between the patient and the therapist is a reciprocal one, and that the patient's behavior can have a very important influence on the therapist's behavior, and that what often goes on in treating borderline patients in particular, and possibly many difficult to treat populations, is that the patient often inadvertently reinforces the therapist for doing essentially ineffective treatment and punishes the therapist for doing effective treatment. And that what happens over time is that the therapist slides from a treatment that might have been effective if they had stuck with it to one that progressively becomes less and less effective over time because of this reciprocal interaction.
When I went through my most difficult session to date with my patient, and I knew the right thing was to call. Like, this is where I need the team to treat me so that I can figure out how to treat my patient. I think had I had a system like that in place, it would have been easier for me to at least make contact with that person. But part of what I was going through was like shame, humiliation, all this stuff.
So the goal of the treatment is to consult with the therapist and provide a balance to the patient and a balance that will keep the therapist within the treatment frame. So the goal of the treatment team is to reinforce the therapist and support the therapist in doing effective treatment and help give them feedback when they're doing ineffective treatment. And at the same time to apply all of the DBT's treatment strategies to the therapist. So what the treatment team has to do is a validation of the therapist. So the therapist comes in ready to tell the patient, and the treatment team says, well, of course, how could you go otherwise? That's the validation part. And then the change part is the problem solving, but what are we going to do about it? Because that attitude is probably going to be harmful in the long run. That's what that team does. It's a weekly meeting. It's become so important in this treatment that I now believe that it's an essential part of the treatment. It's as if I've redefined what I think treatment is. I used to think it was a relationship between a therapist and a patient, or a therapist and a patient group. And I now think that it's the relationship between the patient and the therapist, and the relationship between the therapist and the team or system. And it's that whole circle that's the treatment. So the goal of the treatment team is to consult with the therapist and provide a balance to the patient and a balance that will keep the therapist within the treatment frame.
My experience in working with borderlines as a case manager was that though there were people around, I felt very much that I was doing the work on my own.
Provide a balance to the patient, consult with the therapist, and provide a balance to the patient and a balance that will keep the therapist within the treatment frame.
My experience in working with borderlines as a case manager was that though there were people around, I felt very much that I was doing the work on my own. And I think that what I'll be able to get from the team is a much more ability to be able to live with the sorts of issues that borderlines present on a daily basis.
The fact that mental health practitioners are really supporting me, and I in turn are supporting them, and that we don't have to look for that affirmation from our clients. You know, is that we're working together on this, and we know that there's somebody that's supporting us, so you don't have to feel so alone in dealing with your clients.
The goal of dialectical behavior therapy is to help people with borderline personality disorder find hope and forge a life less encumbered by emotional chaos. But how effective has DBT been in treating these patients?
There are a lot of ideas about how to what this treatment has going for it at the moment, which others may have before long, but at the moment it's the only one that's got this going for it, is a controlled clinical trial data demonstrating its effectiveness.
Dr. Linehan conducted a one-year study of DBT, treating 24 women with a history of suicide attempts and self-injury. These were compared to a control group of 23 similar women who received standard treatment. The number of self-injury attempts among the DBT group was nearly half of the control group. And the number of hospital admissions over the same period showed that, again, there were half as many from the DBT group as the control. However, despite these improvements in outcome, Dr. Linehan does not consider DBT to be a cure for borderline personality disorder.
I think we have to be completely clear about something, which is this treatment's not very good. It's the best, but it's not good. We don't know how to treat these people well. What we can do with this treatment is as much as we can do, but we simply got to do better than what we're doing. And this treatment's got to get better. And this is why I'm fundamentally a researcher rather than a practitioner. It's because someone's got to stay home and try to make this thing better. And so that's really what I'm doing, is I'm continuing the research, trying to improve it. And hopefully it'll keep improving, and many people who apply it are going to make it better, and community mental health centers are going to make it better, and managed care is going to make it better, and hospitals will make it better. In other words, I think everyone who uses it probably will be able to contribute and make this treatment better.
For most clinicians, for most family members, for most people with these problems, the most devastating and terrifying aspect of life is the risk of suicide or self-mutilation. That's your primary step, your first goal. Tell us what you do.
The first thing I think you have to do is that you have to recognize that if suicidal people could manage their lives and make them bearable in some other way, surely they would do that. So you have to assume that they in fact can't do something else that would work. So the first thing you have to do is you have to improve their capabilities.
How does one use what you teach in workshops on this tape? Tape in your books. How does one use that in everyday practice with the next patient? If one doesn't have the whole team and doesn't have the total experience of applying treatment.
I don't know, I would probably respond to that by saying you take what you can get. I mean, you take what you can take. I mean, obviously, if you can't do the whole thing, you have to take what you can take. And you take whatever seems reasonable and whatever you think is going to fit into your practice. It's a long-term question, and we have to do a lot more work and research to find out how much of it you have to get the same results that we got in our research. That research hasn't been done. My personal belief from doing the training that I've done around the country is that almost everybody can take almost all of it. Because what most people don't realize until after they've learned it is that before they learned the treatment, almost everybody's doing 80% of it. It's not as if this is an entirely new thing. If it was, I'm sure no one would like it. It would be too way out. But everyone's doing 80%. So most people only have to learn 20% anyway. And so it's just that the 20% one person learns is different than the 20% another person learns. So you need to find the 20% that's not your 20%. See if you like it and put it in.
Lots of times the individual person or the family loses hope. Sometimes the therapist or the treatment team loses hope. The long-run prospects for most people are pretty good. How do we somehow or other get people through the rough patches that so often make it difficult what we're seeing?
If the patient loses hope, or the family, and the therapist has contact, obviously, with the patient,
First one example I found in the skill might be used with the clients. Listen to what example I found. Does not need to process, but you should provide navigation with the client's skill.